exenatide, dapagliflozin, or phentermine topiramate differentially affect metabolic profiles in polycystic ovary syndrome. Okay, so a bit of background from the paper itself. PCOS is one of the most common gynecological conditions, and it arises from multifactorial contributors, including genetic, epigenetic, and environmental factors. There's growing evidence that PCOS is linked to inherited insulin resistance, and this has led to trials of anti-diabetic in patients with PCOS. Currently, a number of anti-diabetics have been approved, which facilitate weight loss and improve underlying insulin resistance. We know the favorable effects of GLP-1 receptor agonists in patients with type 2 diabetes, but there are a limited number of studies that have looked at the effect of GLP-1 in patients without diabetes, and same goes for SGLT2 inhibitors. Studies of these drugs in patients are also limited. This paper has referenced these studies, which have shown weight loss benefit of both GLP-1 and SGLT2 in patients with PCOS.
Kind of cause a gynae diagnosis, isn't it, rather than an endocrine one?
Actually, I was going to say endocrine as well, but that's what the paper has called it.
Yeah,
actually.
it's
so
all right. Yeah.
So coming to the present study, it was conducted to measure the effect of 24 weeks of treatment with exenatide once weekly, dapagliflozin, either alone or in combination. Combination of dapagliflozin and metformin extended release, and phentermine topiramate extended release on metabolic profile and body composition in obese non-diabetic women with PCOS. The study was randomized trial, single-blind perspective. The study length was 24 weeks, and it was conducted at Women Hospital Endocrine and Weight Loss Clinic in Louisiana.
So phentermine's been banned in the UK for this kind of thing. So that's interesting choice. Yeah.
It's pretty recent, actually, from 2016 to 2020, I think, yes.
I know, but... Well, that's a mixture. In the UK? In the US, yeah, okay.
So the eligible participants for the study were non-diabetic obese, BMI between 30 to 45, premenopausal women aged between 18 to 45 with PCOS. For PCOS, the participants were required to have combination of irregular periods and biochemical evidence of hyperandrogenism. Patients with known bleeding disorders and androgen excess were excluded. Also, the participants were required to have an agreement to use effective contraceptive throughout the study period. Patients with diabetes, current smokers, suspected pregnancy or desiring pregnancy, those who had used injectable hormonal contraceptive in the last 6 months or were on oral contraceptives or other steroid hormones were excluded. Also, patients who are on drugs that affect gastrointestinal motility or carbohydrate metabolism, or anti-obesity drugs within 3 months prior to the study entry were also excluded. So a total of 130 participants provided consent. 11 were excluded after initial screening. 119 women then were randomly assigned by computer-generated block allocation sequence to one of the 5 treatment groups, and all patients were assigned as an individual study identifier. Training personnel using standardized protocol obtained anthropometric data at baseline, 12 weeks, and 24 weeks at completion of the study. So body weight, height, BMI was measured, waist circumference, waist to hip ratio, and waist to height ratio were calculated to use as a marker of abdominal adiposity, and blood pressure was measured. The lab assessment included OGTT at baseline, at completion, and at completion of the study. So they took blood sample at baseline, 30 minutes, and 60 minutes, and 120 minutes for glucose and insulin. Fasting samples were obtained for total testosterone, pre-androgen index, SHBG, and DHEAS. Fasting lipid profile included total cholesterol, LDL, HDL, and triglyceride. For all patients, electrolytes, creatine, LFTs, TSH, prolactin, and beta HCG was measured. Total and regional body composition was determined using a DEXA scan. So for each body region, head, trunk, arm, and legs, fat and lean body mass were measured and expressed as mass in grams. The total body fat percentage was calculated by dividing the weight of the total fat by body weight. Ratios of regional DEXA mass compartment like android to gynoid fat mass have also been used to stratify risk for metabolic disease. The android region is typically defined as the region between the last thoracic rib and iliac wings, and the gynoid region is glutofemoral region. Similarly, trunk to leg fat mass was measured and trunk to leg fat ratio was calculated. And they have referenced these studies for the significance of android to gynoid ratio and trunk to leg fat ratio. So this is the flow chart of the trial design. 130 women consented, 11 excluded, so the total number was 119. For all the participants at baseline, they underwent anthropometric measurement, OGTT, and a DEXA scan. In exenatide only group, 23 patients were enrolled. 22 were in the dapagliflozin and exenatide combination group, 23 in dapagliflozin, 26 in dapagliflozin and metformin extended release, and 25 in phentermine to pyramid group. The dose of exenatide was 2 milligrams. The dose of dapagliflozin used in the first 3 groups was 10 milligrams. The dose of dapagliflozin and metformin was 5 milligram and 1,000 milligram for 4 weeks initially, and then increased, doubled after 4 weeks. And similarly, the phentermine to pyramid group was 3.75 and 25 milligram for the initial 2 weeks, and then doubled afterwards. All of the participants attended again at 10 to 12 weeks, at which stage the measurements were repeated. There was one dropout at 10 to 12 weeks from exenatide group. They haven't said the reason. It was as per patient request. From the dapagliflozin and exenatide combination, there were 2 dropouts, one because of side effect, one patient was non-compliant. From the dapagliflozin only, there were 4 patients, 4 dropouts. One patient moved, one had concern about medication, one was non-compliant, and one was removed from study because as per her physician, but again, the reason wasn't mentioned. In the dapagliflozin metformin group, there were 6 dropouts. 4 did not tolerate and had undesirable side effects. From the most dropouts were actually from the phentermine to pyramid group. There were 5 in the first at first visit. After at the second visit at 22 to 24 weeks, again the anthropometric measurement was taken again, and all the participants underwent OGTT and a DEXA scan. The final study population was 20 for exenatide group, 20 for the dapagliflozin and exenatide combination, 17 for the dapagliflozin, 19 for dapagliflozin and glucophage metformin, and for 16 for the phentermine group.
Just to be clear, in this pathway, there's no crossing over. They all just went straight down, but they've had 2 assessments and some have dropped out on the way. Is that the summary of this slide? There's no crossing over, is there?
No crossing over, no. So what they have said is that if the participant dropped out, they were replaced.
Oh.
Yes, they were replaced so that they had a kind of similar number of the required number of participants, which they calculated about 120.
Okay, so for example, the dapagliflozin alone group have gone from 23 to 17. They've lost 5. Yeah?
Yes, so 4 dropped out initially, 19, and then 2 further drop out. Yes, so actually
yes.
Is this one, yes.
So we can't see the small print so easily, but the small print says things like 4 drop out, 1 patient moved, 1 concern about meds.
Yes.
Yeah, okay.
1 non-compliant, 1 removed from study as per physician, and then 2 further dropout, 1 required major surgery, and 1 was non-compliant.
So but I can't see any replacements.
So from the the 23, yes, actually, yes, that's right, Prof. Sorry. So from the first one dropped out, and then 2 dropped out, and actually 23 dropped down to 20.
Yeah.
Yes.
Okay.
22,
that's clear. Thank you. I was just giving that's nice and clear. Thank you.
So before coming to the results of the study, the paper actually talks about assessment of the insulin sensitivity measures. So they did not use hyperinsulinic euglycemic clamp, but have used indices derived from fasting or OGTT stimulated glucose and insulin values. So the homeostatic model assessment of insulin resistant, HOME-IR, is a method used to quantify insulin resistant and beta cell function from fasting glucose, insulin, or C-peptide. It is calculated as fasting insulin into fasting glucose divided by 22.5. The insulin sensitivity index uses ratio of plasma glucose to insulin concentration during an OGTT. This Masuda insulin sensitivity index is the index of whole body insulin sensitivity and is measured by the formula 10,000 divided by under root of fasting glucose into fasting insulin into mean plasma glucose from OGTT and mean serum insulin from OGTT. Early pancreatic beta cell response is estimated as insulinogenic index corrected for by the relative level of insulin resistance. So the insulinogenic index is calculated as insulin 30 minutes minus insulin 0 minute divided by glucose 30 minutes minus glucose 0 minute from OGTT divided by the HOME-IR from above equation. We talk about the collateral research. So to evaluate abdominal adiposity, a waist circumference greater than 35 inches, 89 centimeter, and waist to hip ratio greater than 0.8 and waist to height ratio of more than 0.5 were considered to be elevated. The mean blood glucose concentration were taken from the OGTT sample 0, 30, 60, 120 minutes divided by 4. Hyperinsulinemia was considered when fasting insulin were greater than 10 and greater than 40 after the glucose load. And the triglyceride to HDL ratio greater than 3 was used as indirect measure of insulin resistance. So these are the baseline characteristics of the study participant. The first group is the exenatide, second is exenatide plus dapagliflozin, third is dapagliflozin, fourth dapagliflozin and metformin, and the fifth one is determined to pyramid. I've highlighted the fasting blood glucose and mean blood glucose, so ranging between 92 to 98. Just for our units in millimole per liter, 94 would be about 5.2. And 128 would be 7.1. The total testosterone was around 1.59 nanomole per liter. The cholesterol 4.9. Sorry, I've just converted one of them just to give an idea of how much is it in the units we are used to, and the triglyceride around 1.5. The BMI was above 35 for all patients, and the waist circumference was between 103 to 111. And they were normotensive. After 24 weeks of treatment, these are the results. So this table here, I put the baseline characteristic again, and this table shows post-treatment glycemic, anthropometric, and metabolic parameters affected by all drug treatments. So the fasting glucose was reduced in all groups, roughly from 92 to 98 milligram per deciliter to 87 to 93. Fasting insulin sensitivity as determined by HOME-IR was also improved in all treatment groups. Total testosterone concentration was also improved in all treatment groups. The level of the lean body mass also improved. The level of cholesterol and HDL, LDL were not altered by any treatment group. This table, again, I've put the baseline characteristic here. This table is post-treatment glycemic, anthropometric, and metabolic parameter differentially affected by the drug treatment after 24 weeks. So the reduction in mean plasma glucose for patients who were on combination of GLP-1 and dapagliflozin was significantly more as compared to the other treatment groups. The corrected early insulin response to glucose challenge was not significantly altered in all treatment groups. An increase was seen in combination of GLP-1 receptor agonist and dapagliflozin group only.
We need to remember what the baseline was because there's no control group, is there?
Yes, so the baselines are actually on this table. Do you see my cursor?
I see.
Yeah, this one. These are the baseline. These are.
So the left is the baseline, and the right-hand table too. You've put them to. Thank you. I see.
Yes, and I've highlighted them because we kind of color coded them because they're not online. So the mean plasma, so the mean plasma glucose for the for the exenatide dapagliflozin dropped from 130 to 112.
Yeah.
Similarly, the IGI home IR insulinogenic index, it went from 0.6 to 0.9, an improvement. Similarly, I haven't highlighted it here, but the insulin secretion sensitivity index actually also improved.
Yes,
for this,
I'll see the problem. On our big screen, these numbers are too small to read, but I'm going to just, the summary really is the left-hand screen are all the same, baseline. The right-hand screen shows, in tiny letters, it says P less than 0.02, 2 versus 3, 4, and 5. So in other words, the combination of DAPA and EQW was better than the others, yeah?
Yes, exactly. I've put the conclusion in the next slide. I'll
okay.
Go through them, yeah.
Ambreen, can you hear me?
Yes, I can.
Yes, okay. Sorry, just a quick question. I might be getting confused, but on the baseline characteristics, so in their inclusion criteria, they required biochemical hyperandrogenism.
Yes.
But actually in the baseline characteristics table, I think the one you showed before, slide before, their total testosterone was 1.5, so within the normal range, and their free androgen index was below 8.4, so normal as well.
Yes, and they haven't said what's their cutoff. In the introduction, they said about above 50, so they wanted it above 50 would be around 1.7 for us actually. And when you look at the baseline, they've said 47 plus minus 2 for one group, 47 plus minus 4.3. So yes, I agree actually that the inclusion criteria actually said that it has to be above 1.7. In the study group,
did they do ultrasounds on these patients or not?
No, they didn't do ultrasound. This is just a DEXA scan.
So our criteria for diagnosing PCOS in this study is basically irregular menses and upper range androgens, basically.
Exactly.
Which is not really the criteria for diagnosing PCOS. So there's a problem with the actual study group, I guess, yeah?
Yes, and they haven't actually, I'll talk about, but they haven't even talked, at the end, they don't talk about clinical features like hirsutism or menstrual regularity at the, the outcome of the study.
Okay, that's useful. Okay, thank you.
So coming back, so the weight reduction again was significant according to this paper in the exenatide and dapagliflozin group and the phentermine topiramate group. Similarly, the waist circumference and waist to height ratio showed significant reduction in the exenatide, dapagliflozin, and phentermine and topiramate group. And combination of dapagliflozin and again phentermine topiramate were more effective in promoting weight loss of total body fat. Level of abdominal adiposity as based on the android-gynoid ratio and trunk to leg fat mass ratio was reduced in all treatment groups, but more significantly so with the dapagliflozin and GLP-1 receptor agonist combination as compared to the dapagliflozin alone. Also, they showed that the triglyceride concentration was reduced with the combination of GLP-1 receptor agonist and dapagliflozin, which was more statistically superior to the phentermine and topiramate group. They also suggested that the fasting insulin sensitivity was significantly associated with android-gynoid ratio in these obese hyperandrogenic women, and there was stronger negative correlation between peripheral insulin sensitivity as calculated by Matsuda's sensitivity index and central adiposity as defined by the android-gynoid ratio.
That's a baseline.
Yes, at baseline, yes.
Yeah.
That's at baseline. So this is a graphic representation. So it's the treatment group 1 is the exenatide, 2 is exenatide plus dapagliflozin, 3rd is dapagliflozin, 4th is dapagliflozin metformin, and 5th is phentermine and topiramate. And the insulin sensitivity index was significantly improved after 24 weeks of treatment with group 2. The mean weight, the percentage change in weight loss from baseline after 24 weeks actually was better for the for group 2 and group 5, which is exenatide and dapagliflozin and topiramate and group. So adverse effects were more common, and dropout were mostly in the phentermine and topiramate group. The exenatide group had upper GI symptom like nausea. There were UTIs in the dapagliflozin group, 2 and 2 patients, but none of the participants had any adverse, serious adverse effects. So to come into the conclusion as per this paper, so this was the first randomized control trial comparing the clinical efficacy of GLP-1 receptor agonist exenatide and SGLT2 inhibitor dapagliflozin in combination and alone, and dapagliflozin metformin and the weight loss medication phentermine and topiramate on metabolic, anthropometric, and hormonal parameters in obese non-diabetic women with PCOS. The dual treatment with exenatide and dapagliflozin was clinically superior compared to other therapies. All therapies consistently lowered blood sugar, resulted in improved insulin sensitivity, estimated both by HOMA-IR and Matsuda's insulin sensitivity index. Participants on all therapies showed significantly improved glucose excursion during an OGTT after 24 weeks of treatment with an individual on the combination of exenatide and dapagliflozin, showing a significantly greater drop in mean blood glucose compared with dapametformin, and phentermine and topiramate group. Overall carbohydrate metabolism, as estimated by patient insulin secretion sensitivity index, improved steadily over 24 weeks in all groups, with exenatide and dapagliflozin showing significantly greater improvement than other groups. A combination of exenatide and dapagliflozin and metformin and topiramate and phentermine resulted in greatest weight loss, total body fat with DEXA, and waist circumference compared to DAPA alone or DAPA and metformin combination. The improvement in central adiposity was most dramatic again with exenatide and dapagliflozin and phentermine topiramate therapy, whereas mean waist circumference and mean waist to height ratio measurement significantly decreased over 24 weeks, and central adiposity was not as reduced at 24 weeks with DAPA and metformin combination. Decrease in android gynoid ratio was found with all treatment. Again, exenatide and dapagliflozin combination was superior, and they've called a significant reduction in testosterone levels in all treatment groups, consistent with weight loss observed with all treatment groups. Although participants were not allowed to get pregnant, as in use contraceptive, but 4 got pregnant during the trial, and they've called it return of ovulatory function. So the study was randomized, included a weight loss medicine, and has shown a therapeutic effect of exenatide and dapagliflozin alone or in combination, which has never been evaluated in this subpopulation of obese women with PCOS. The limitation is sample size is small. There's lack of data on clinical manifestation like hirsutism and menstrual regularity. The paper actually has said that when the participants initially were enrolled, they were encouraged to undertake lifestyle modification and exercise, but they have not evaluated that. And although the weight loss and particularly differential weight loss seems quite appealing, but in a publicly funded system like NHS, cost effectiveness would be a consideration for intervention like DEXA to look at the body mass compartments, and again, similarly use of GLP-1 receptor agonist in this population.